My name is Bettina Moser. So I'm a pelvic physio, and I have a variety of interests. So my primary interest is that I'm a pelvic physiotherapist, and I have an interest in bladder, bowel, and sexual function. On top of that, I have a master's life coaching certificate. So my interests in a TRE, I'm a TRE provider, which is tension and trauma release. So really, my current passions are more related to more a mind, body, or holistic type of approach to our health and well-being, and looking at how all of these interact. So sometimes I'm not completely in my full kind of medical box, and I may step out and look at how our emotions or how various past experience can affect various things. So you may notice that I do occasionally refer to that. I just want to introduce my co-host, Hester van Aswegen. So Hester and I are and have worked together for numerous years. We have taught together, and we are both passionate in kind of patient care and teaching and various kind of ventures. We together were involved in the pelvic floor unit at the Wits Donald Gordon for many years. So I don't know, Hester, if you can pop your video on, then I can just touch base with you. There we go. So many of you will know Hester. So hi, Hester. Thank you for joining us
Hi,
today.
Bettina. Thank you for inviting me.
So what we're going to do today is that we're going to discuss specifically pelvic organ prolapse, and Hester is going to kind of be on the sideline taking your questions. So if you don't mind, when we are, I'm going to discuss just basically the kind of prolapses we get. We're specifically talking about the female now, so we're going to look at women and their types of prolapses, specifically vaginal prolapses. So we're not going to look at kind of anything that's happening in the posterior compartment or the back passage, but we're looking specifically at the female, and we're going to look at what type of prolapses, how what they're called, how they're managed, and in between I'm going to stop periodically so that you can please pose your questions. So we'll pop it down into the little Q&A portion at the normally it's at the bottom, and just put your questions into there, and they are anonymous, so you don't need to worry about anything, and we will just bring them forward. Hester will have a look at them, and then we'll address those as we go along. So you know, the nice thing about this is that you can pose your questions, we can discuss them, we can look at things, you know, and the nice thing is that Hester and I have slightly different ideas and different approaches and ways in which we have our clinical reasoning and approach to things, so we can just banter about what we would both do in various situations. So you take the opportunity to take advantage of asking your various questions. So what we find, or what I find usually, is that this is such a taboo topic, and I'm sure you relate to that, Hester, that often when we see patients coming in, our first entire hour session is more around education and helping you understand the problem. And you know, the thing is, if you can understand your own body, what is happening, why it's happening, how one can go about correcting that, then all of a sudden it's not such a mammoth thing anymore. Whereas it can feel quite frightening when you get this diagnosis, this fancy diagnosis, and what is this, and what do we need to do? And whereas when you can really just understand some anatomy and physiology and the basics of that, it's just quite empowering in your decision making with regards to where to from here. I don't know if you have anything to add to that, Hester. Otherwise, I'm going to screen share and we're going to get going.
No, I think let's get going, and then we can address the questions as we go along.
Okay,
Perfect.
great.
Thanks.
All right, so let's see. Okay, so we're looking at pelvic organ prolapse then today. So is it letting me change my, let's see if it's going to let me change my, this is the joys of technology. Let me come out of it again. Sorry about that. I'm not being given permission to move my slide along. Let's just see if we can do it here. Let's see. There we go. That one likes it better. Okay. So let's start with just simple, what is a pelvic organ prolapse? So really a pelvic organ prolapse is when one or more of your organs in the pelvis specifically, and here in the vaginal area, starts to move out of its normal anatomical position. So where before it would have been sitting up here, it's now coming and leaning slightly into the vaginal canal, and from there a variety of symptoms can come from that. So how does one come to a point of getting a pelvic organ prolapse? Now, as women, we are far more prone to pelvic organ prolapse by the nature of our anatomy, by the nature of the fact that we have a vagina, which is an open kind of cavity in a way, versus men will have a far more solid pelvis. And also just the nature of the fact that we carry babies, deliver babies, and all of that makes us far more prone. But it doesn't mean that men don't and can't have prolapses, but they're less likely to. So the first and the primary thing is pregnancy. And just the nature of a pregnancy can and does already put pressure on our pelvic organs. So if you are carrying quite heavily, and they generally say that a pregnancy over 20 weeks already starts to put some pressure on your pelvic organs. So whether or not, whichever mode of delivery you may choose in your pregnancy, the pregnancy alone already does and can affect one's position of one's organs. So what happens is that the ligaments stretch by the nature of the pregnancy hormones, and already then the weight can provide some pressure into that area, and the area is more lax. So you're more likely to stretch that area. And then by the nature of the type of delivery that you choose, obviously a vaginal birth will, by the nature of the fact that the trauma is in the vaginal canal, that you're birthing through that area, you're pushing, there's pressure down, that can and is one of a higher risks of pelvic organ prolapse. But it doesn't mean that women who have had cesarean sections cannot and don't have pelvic organ prolapse. So that's often a question that can be confusing for some, because they feel like, but why do I have a prolapse? I had a cesarean. So there are many things that can contribute to this. The other is constipation. So if you are anything that's pushing down all the time, so always heavy. So if you are constipated, you're bearing down, you're pushing down, that in and of itself is putting an ongoing pressure into the pelvic organs and pushing everything down. The other thing is surgery. So very often when we have had as women surgeries in those areas, there can be a disruption of some of the ligament structures. There can be some the anatomy is not necessarily the same. There can be scar tissue, there can be areas of weakness, and the typical surgery that is associated with prolapse is hysterectomy. And the irony is that many times hysterectomy is done for prolapse. So when the uterus does descend and there is a dropping of the uterus, then very often a hysterectomy is performed, and it's kind of, well, then everything goes away. But the nature of that actually causes some disruption in that area and can actually make a woman more prone to prolapse after a hysterectomy. So that's something to bear in mind. The other thing is heavy lifting. So if a lot of our nurses, or a lot of our careers, or even just carrying your grandchildren, or if you're on pregnancy number 4 and you have other children that you're lifting or carrying, that in and of itself is adding a heavy load onto that area that could have been affected by either a previous pregnancy, a previous delivery, a surgery, or something else that's coming into the mix. So really, when we're talking about prolapse, we are talking about keeping the pressures at bay. So basically, um, the lift up needs to be there and needs to be stronger than the push down. So when we're in a position where the weight down is stronger than what we are supporting up, we're putting ourselves at risk for some type of descent of the organs. So that takes us on to things like obesity as well. So when there is a lot of weight being carried around the tummy areas, again, there's a lot of pressure down. And then it's the things like respiratory problems, chronic coughs, um, asthmatics, that type of thing. And obviously COVID comes into this at this point in time. So if there's anything going on in that capacity and you like coughing regularly, then what'll happen is that you're more likely to put pressure in that area. So smoking can be a contributing factor. Smoking also affects the tissue, the quality of the tissue. So those are the types of things that would make you more prone to developing a prolapse. So when we're looking at how do we start to correct a prolapse or manage a prolapse, these are the types of things that become important in the management of prolapse. Because if you are trying to manage a prolapse, and it actually doesn't matter whether you're managing it conservatively, i.e. trying to avoid operation, or whether you are planning to have an operation or are post-surgery, you still need to manage and protect that area. And if you are chronically constipated and you're pushing regularly, or you're moving furniture around, or you're a nursing sister and you are working in ICU or in theatre and lifting patients, or have struggled with obesity or chronic coughs, you're more likely to have recurrent prolapse. So not only does it affect the current situation, but also the situation post-treatment. If you do have a surgery, this is often why our surgeries will fail. So for me, this is quite an important slide to just really understand how, when, where, and where do we go from here. So looking at specifically the female vaginal area, we have various types of prolapses based on the type of organ that is prolapsing or moving out of position. So when you go to the doctor and they say you have a cystocele, what is happening there is that the bladder is moving out of position. A rectocele is the rectum is moving out of position. And I'll show you pictures of this so that you can start to understand, because when you are and sometimes you don't even know that you have a prolapse. It is by diagnosis only. There are no symptoms attached. And even if there are symptoms and you feel that there's something happening down there, you're not going to know what type of a prolapse it is necessarily. And you don't necessarily need to know, okay? But it's interesting to know so that you can start to understand how this all fits together, and how the management would then fit together. So for instance, if it's the rectum that's bulging and leaning into the vaginal wall, if you are constipated, that will significantly affect that rectocele from just the fat of the stool coming down. But just the pressure will also affect the other organs, the uterus, the bladder, so the other thing that we get is a uterine prolapse. So that's from the top down. So the top of the vaginal canal is where the uterus is. And when the uterus is removed in a hysterectomy, we call it a vault. So it's just kind of the top of the vaginal canal, and even that can come down. So and prolapse out of position and feel quite uncomfortable for women that don't actually have a uterus. And then you get something that we call an intracele. Now, an intracele is where the organ is the small bowel. So what happens here, and I'll show you pictures, that the small bowel actually comes down, and it's usually related to a surgical intervention or tearing or something happening in that area. Okay, so if we look at a cystocele, so this picture on the left is a cyst. So if you're looking at the anatomy, this picture on the left is the cystocele or the prolapse bladder. In the front, you've got your pubic bone, okay? And then at the back, you've got your spine and your coccyx. So what's happening is that you will first encounter your bladder, thereafter your vagina, uterus, and then your bowels. And what's happening there is that that front vaginal wall has become weakened or slack or distended. And what's happening is that the bladder almost just like leans into that vaginal cavity, and it causes a type of a bulge coming in to a greater or lesser degree. So that bulge can just be a small little bulge that is internal, that's not noticed, it's not visible, to a greater and greater bulge that can actually come towards the vaginal opening and then protrude out of the vaginal opening. And those are the different stages of prolapse. So sometimes you may not even know that you have a prolapse. You might go to the gynecologist for your checkup and they'll say, oh, you have a prolapse, a stage 1 or a stage 2, and it depends on how far it's come down, okay? So when you're looking at the picture on the right, this is a rectocele. So here again, you've got your pubic bone in the front, you've got your bladder, which you can see is now nicely supported, your uterus, vagina, and the rectum. And what happens here is instead of it being nicely supported as in this first picture, it's leaning into the vaginal wall, but it's the back part, the posterior part, and it basically leans into that vaginal area and again causes a bulge. And are you going to know what bulge that is? No, you may not even see a bulge, but it is labeled or recognized and diagnosed by the organ on the other side. So if the organ is the rectum, it's going to be called a rectocele, and if it's the organ is your bladder, then it's going to be a cystocele. So when we're looking at your uterus, so here you've got a normal, so this is now flipped back to front. So you've got your pubic bone in the front, you've got your bladder behind it, which is in a nice position, you've got your uterus, which is in a nice high position, vaginal wall, and your rectum. And what happens here is in this picture on the right, you can see that the uterus has started descending. Um, and the cervix comes down, and the cervix is basically the top of the vaginal canal as the uterus starts. So what some ladies will say is that they'll feel as so the cervix feels like the tip of your nose. So they might find that if they're inserting a tampon, or if you're inserting a finger, you'll notice that is quite low down versus being quite nice and high up. So that's a uterine prolapse. So if, for instance, we have a situation where there's been a hysterectomy, so here the uterus would have been removed and they kind of stitch and suspend and support this vault up here at the top of the vagina. And then if that starts to come down, we have what we call a vault prolapse. So that kind of tends to come down a little bit post-surgery. And after that hysterectomy, by the nature of the fact that we've cut and removed, and there are a lot of ligaments that are suspending and holding all our organs up. And when we've had surgery, they have to almost cut through a lot of that, and then they artificially try and mimic a certain amount of support. But yet, the pelvis is nothing supporting from underneath. We stand upright. It's not like we kind of walk on all fours where the pubic bone's at the bottom. So we don't have bone or any support structure at the bottom other than our pelvic floor muscle. So when you're upright, there's actually this cavity, and and gravity becomes a big problem. So this is where we start to have these challenges even with surgery, in trying to actually support everything. Right, so here is what we call an intracele. So again, if we go to the top, here is your pubic bone in the front. You've got your bladder, your urethra that you wee out of, your uterus, vagina, your bowels. And then kind of up higher up, you've got your small intestine. If there's been some type of surgery or disruption or anything of kind of, there is almost like a fascial space here that kind of separates the two. And if there's been some surgery or disruption, what can happen is that there is some tearing in that, and you actually have a position where when you're pushing down or bearing to go to the toilet, that it may lean down into kind of the more pelvic areas. So this is not one that comes out of the vaginal canal, but it's more kind of squeezes in between. It usually squeezes between the back part of the vaginal wall and the rectum. And I'm mentioning this because very often, if you have seen one of the doctors and you have a rectocele, very often they'll say, that there's a rector and enterocele, and this is what an enterocele is. So it almost comes down here usually, and it can feel uncomfortable. So ladies may complain that when they want to pass a stool, they kind of, the sensations are a bit strange. They can't empty properly because of this actual enterocele coming down. It's shown clearly here in this bottom picture, where it just comes down into that almost space there. And you can imagine that it must feel quite strange to kind of have that there. So very often people think that there's a stool there and they need to go to the toilet. Nothing wants to come out. So if you kind of have a rectocele, that might be the type of things that you may feel sensation-wise. Okay, I'm going to stop there for a second. Hester, let me know, are there any questions? Is there anything related to the types of prolapses or anything that we need to clarify in the anatomy of what's happening there before we carry on?
Bettina, I think one thing that somebody has asked is, how does menopause affect all of this?
Your video's off,
So,
Hester.
sorry,
If
let's
you want to
put that
pop it
on.
on. Okay, so menopause is a hormonal shift as we age. So the thing with menopause is that it changes our hormones, and our estrogens change. So by the nature of that, we are not as hormonally strong, if you want to call it that. Our hormones are not protecting the environment as much, and our tissues get weaker. They become less pliable, and in that way we're more likely to develop prolapse, and we generally at an age where all the other things are compounding. So we may have had our babies, our pregnancies, we may have had some miscarriages, or so it's not only just our the births that we the babies we do deliver, but it's also related to if you've carried if you've miscarried later on, perhaps. It's a hormonal thing as well. So, and on top of that, we may be weaker, we may not be as strong, and then we enter a phase where we have a hormonal change called menopause. And I think more than wanting to blame menopause, I think it's compounding. So it's kind of like it's another thing in the mix. I don't know if you want to comment about the menopause discussion,
No, I
Hester.
think what you said there now, this last comment about it's not only menopause, there's so many other factors, because very often we will see that you've had a history of being constipated for a long time, and maybe you did have one or two vaginal births, of which one might have been a little bit traumatic, and you could have had back pain, a history of back pain, and maybe you were then trying to really exercise your core quite intensely and maybe not always activating the muscles correctly. So there's very often more than one factor contributing. So we shouldn't only blame one thing. And then sometimes people are like, but why do I suddenly feel this? And it's probably not really been sudden. It's probably been developing over a period of time, but maybe you just didn't realize it. The symptoms were quite subtle. And then suddenly in menopause, that's the time where it now presents. Just like you say, because we probably are a little bit weaker as we get older. But yeah, unfortunately, the hormonal changes do change things in our bodies. So
And if I
something to
can just
consider.
comment on something that you mentioned now with regards to, and I don't want to forget to mention this thing that is on the table at the moment, is the exercise that we do. So,
Yes.
and we'll chat a little bit later, but I'm not sure if I brought it into our slides, but we under heavy lifting, when I said the causes are also
Mm.
like in that heavy lifting is also weight training. And very often we starting these very intensive, or in my opinion, very intensive trainings in our kind of 40s and 50s and CrossFits, and it's at a time where we even like even if we're running marathons and stuff like that, it causes a lot of it's a lot of pressure in that area, and it's at a time in our lives. For instance, the Comrades runner is not the runner in their 20s. Okay, the Comrades marathon runner is in their 40s, 50.
The
So
oldest person.
and
Yes.
often our bodies are I think not always able to cope with that. So, but for me, I the weight training, the CrossFit, all of that can also it's about the balance of the pressures. So if we're putting a lot of pressure down, doing lots of crunches without giving the support from the bottom, you're not
Absolutely.
allowing the area to be supported. And then what happens is, like Hester was saying, then menopause arrives and adds another like component to it.
I mentioned.
And something that may have kind of been prolapsing, and so it's just like a tampon. I generally use the tampon analogy as when you insert a tampon and it's positioned in the right position, and it's high up, you don't feel it, it's not uncomfortable. It's almost just when that prolapse and when that tampon gets saturated and drops a little bit or whatever, that suddenly it's like, oh, that's uncomfortable. And
Mm.
that's exactly like a prolapse. So you may have had a prolapse for 10 years already, or 20 or 30 years, and it was sitting at a level like the tampon in the higher aspects of the vaginal canal, where our sensory capacities are different. So we don't feel it as abnormal, and it doesn't matter. And then suddenly it kind of creeps down, and maybe various things come into play, including menopause. And suddenly it's in that space where you can suddenly start to feel that it's uncomfortable. So, yeah,
Absolutely.
great
And I think
question.
that just another aspect that I think that people are often quite worried about is they feel like, how bad is my prolapse? And the fact that you have a prolapse, people get a little bit freaked out about that. And I think it's also important to understand that if you've been pregnant and things have stretched a little bit, that a lot of women probably will have a minor prolapse, maybe like a grade one. And it's not necessarily a problem. It's not necessarily something that you need to think that you must do much about, besides making sure that you are controlling pressure well and not worsening your prolapse. But if one understands how to control the pressure, if you understand what to do with the correct exercise, you might have a prolapse until the day you die, and you might actually be 100% fine. So one should not be concerned just because somebody said to you, there is a prolapse present. You need to understand how to manage things well.
Exactly. Um, and we'll discuss a little bit about the symptoms of prolapse and how that all kind of presents itself. But the one thing that always stood out for me is the stats that showed, was it over 50, over 60? I don't remember exactly. That said 1 in 2 women have a prolapse. Um,
Yes, absolutely.
so it's quite common, and it's not, but we tend to, it's not dinner party conversation. It's just stuff we kind of want to be. There's almost a shame attached to it. Like, I have a prolapse. What's wrong with me? There's nothing wrong with you. You're a woman. You've had pregnancies. You've
Yeah,
delivered babies. You've looked after babies, be it your own or be it your grandchildren or whatever. You've been through hormonal cycles. It's kind of normal, but I think what is abnormal is that we don't talk about it easily. And because of
yes.
that, it becomes this taboo topic that doesn't need to be that way. And we can kind of, and that's one of the reasons why we've chosen to do these types of webinars, is to actually just bring light into, where we stand with it all. And as you can see, these discussions take a bit of time. That sometimes in a consulting room with the gynae or whatever is not the time that all of this is in a relaxed way chatted about, and when we go to our friend Google, then it's a scary minefield of information that often
Absolutely.
gives the worst case scenarios, and it can be quite frightening. So that's why I say ask your questions. And okay, let me carry on for now then, and then so let's look at the symptoms just briefly. So the symptoms of prolapse, and I'm being a little bit kind of in a box here, in the sense that very often we have a culmination of a lot of different things happening in that area that we're not understanding. And there might be a combination of incontinence with a prolapse, and with some pain and whatever the case may be. And what happens is that we don't know eventually what's what. So someone might, often we have the situation where someone has had surgery and they highly frustrated that they went for prolapse surgery, but the incontinence was not corrected. Or they, and this is the thing, is that sometimes when we have more complex cases or complex presentations in the pelvis, we want to understand specifically kind of what causes what and where the overlap is, so that when we decide on a treatment or assessing a treatment intervention, we know what we're assessing. It's kind of like, if we're dealing with a prolapse aspect of it, prolapses generally feel like that tampon that's falling out, okay, or that heaviness. And I appreciate that in our generation tampons are something that are readily used, so I use that analogy. But kind of in our, my mother's era, that is very far. Like, I don't think she's ever used a tampon in her whole life, so it's not an analogy she can relate to. But basically, it's that bulging heaviness, the feeling that something might fall out. It's specifically the vaginal prolapses generally give that feeling more specific in the vaginal area, but depending, like if it's an intraceal, it can be more pelvic heaviness. It can be associated with some lower back pain, but it doesn't have to be, okay? So specifically vaginal prolapse give bulging heaviness and a feeling of something falling out in the vaginal area, okay? The other stuff could be something else. It could be the prolapse, or it could be a low back pain, or it could be, so that's why I'm just being a little bit boxed here, so that we understand specifically what prolapse is, so that when we get to difficult pathologies and mixed pictures, that we can work out what's what and who's who in the zoo. And sometimes we just don't know, but I think it's important to, so sometimes people say to me, but the doctor suggested that I have surgery. I'm going to the toilet very frequently, and I think that I should address this. And I'll often say to them, but do you have any bulging or heaviness or discomfort in that area? And they'll say, no, I don't have any bulging. And surgery might happen, and they kind of go, but I'm still going to wee all the time. Like, what was that about? And it's important to understand kind of also where our interventions are targeted. All right, so bulging, heaviness, feeling of something coming out are symptoms of prolapse. I don't know why my slides like to hang suddenly. Sorry about this. Let's try again. Let's see if it likes it now. No, sorry about this. Really not sure what's going on here. There we go. Don't know. Okay, one thing I've learned, and it's an ongoing learning experience, is that I thought that only humans were unpredictable. But what I've realized is that IT and computers are far more unpredictable than any human can ever be. So, okay, so then we look at the management of it. So we have two main pathways, and I'm being general here, and I'd like to just answer the more specifics in your questions and answers, because otherwise it gets too complicated. And I think what is important is not to overcomplicate it. There are complicated pictures, and that's, I'm happy to discuss that, and discuss the specific complicated pictures, but sometimes we just overcomplicate things. But really, when we look at the management of prolapse, we have basically two pathways. We have a conservative and we have a surgical. So the conservative is basically avoiding any surgical. And what we do here is that very often, kind of from the physio side, we are responsible for the conservative management. And the types of things that we would look at is things like a behavioral management. So kind of we would assess and see what exactly has possibly contributed to the prolapse, what is contributing to the prolapse, and if there's certain things that are going on that are negatively affecting the current prolapse situation, then it's in our best interest to start to try and manage those. So, if there is a weakness involved, be it in the core, be it in the pelvic floor, be it in the lower back, and all those areas, then it might be valuable to actually address that, strengthen that area up, strengthen the pelvic floor, manage the back pain. Pain inhibits functioning, and it, our muscles don't work very well when we have things like lower back pain or pelvic pain. If we have constipation, it's valuable with a prolapse to manage that constipation, to start looking at your diet, various ways of going to the toilet, making it easier, putting less pressure down into the area, learning how to breathe through those spaces, so that we don't actually go and push everything out every single time we go to the loo. We don't rush on the loo, that type of stuff. If there are exercise programs that are less than optimal or could possibly be negatively influencing that prolapse, then it might be worth actually looking at changing that, or managing it, or strengthening different areas to support the exercise that is currently being done. And sometimes exercises are being done completely wrong, and we actually are causing more harm than good. So there are various things we look at if you are kind of moving furniture around every week, and you are lifting a lot of things, or you're doing a lot of gardening and lifting. It may be worthwhile to look at that and start to help yourself in avoiding certain things potentially, or actually learning to support through other area, through certain activities that we teach the pelvic floor, we teach the area to support before we lift or cough. So with coughing, we try and teach that we hold the pelvic floor up first, so that when you cough, that it actually provides a bit of a platform instead of just every time. Okay, so that involves various behavioral management, various pelvic floor or rehab around that area. But invariably, something that we need to understand is that a prolapse is a prolapse is a prolapse. If the prolapse is there, a conservative management is not going to make the prolapse disappear. Okay, um, it's going to, and that's not the problem. Is not that there's a prolapse. The problem might be that the prolapse is affecting one's quality of life. That if you can support the area better, strengthen the muscle, stop irritating it from above with a chronic cough or a heavy lifting or an exercise program, or with constipation, what happens is that the organs can settle into a more comfortable position. If you go for an examination, are you still going to have a prolapse? Yes, you're likely to still have a prolapse, but it might have lifted a little bit, just like that tampon, it's moved up, and you're actually comfortable for most of the time. Or you might notice that before you were uncomfortable the whole day, and now it's only towards the afternoon when you're getting tired, or your muscles are getting weaker, or it's only after a certain intensive exercise program, or when you're constipated. So you may notice that you can manage your symptoms better, and that is really what we aiming for, is to actually support the prolapse better, because the reason why the prolapse was created is because there wasn't enough support. So actually providing that support is really putting those ingredients back that were not there, and were potentially contributing to that. The other thing we can use on the conservative side, which is a device, and you can see I've put a picture of various pessaries in. So pessary is a little device that we can pop into the vaginal canal to actually support the area, and there are various different types. And this is out of our scope of practice. So what will happen is there are gynecologists that have a special interest, or they not a special interest, but they are pro pessary use, and they can aid you in choosing the right pessary for your comfort. And I've had numerous people who have very successfully used pessaries for an extended period of time in the attempt to avoid surgery, or if surgery was not an option, or there was a situation of recurrent surgeries where we didn't want to go down that route again. But I've seen some good feedback from that. But again, it's a personalized thing and an individual thing, but it is something that can be considered. I wouldn't consider it as a first line necessarily. So you still need to, so if you don't go and change the constipation or the whatever's causing it, um, you're going to keep causing more damage. So I think first and foremost, that needs to be addressed. The areas need to be strengthened. The body needs to learn to work properly. That if you are going to cough or sneeze, that the pelvic floor knows that it needs to support first, so that it's not just everything's not just dragging out, because that in and of itself will also aid in your bowel health, your bladder health, so your urinary incontinence, etc. So it kind of feeds into that whole area. And if we noticing that that is not enough, then a pessary is something that we can look at. And then obviously we have the option of a surgical approach. So and again, with surgery, there's no right and wrong. There's no, but it is something that um, in our kind of prolapse discussion, surgery is a bit tricky, because I think what's happening is that there's a lot of talk around what type of surgery, when, how, who, how do we support. And there's so many, I think, moving parts. So where somebody can say, look, they had a surgery 30 years ago and it was perfect. Another person will say that they had surgery, it lasted 6 months or a year, and then everything started coming down again. And that becomes a problem, because we cannot keep going in and repairing, because with each repair, it's almost like it becomes a bit of a more vulnerable area, and you're more likely actually to have a recurrence. So every time there is a surgery, you're more likely to have another one in a period of time. So this is where a lot of the surgeons will start to become a lot more conservative, and will say rather, so we try and delay and push the surgeries out, so that, because if you are 35, 40, 45 having your first surgery, and that surgery lasts you 5 or 10 years, you're going to be sitting at 50, 55 at your next one. And now remember, you've also got your menopause, and you've got different things coming into play. So, you might then kind of have that compounding, and you may have surgery number 2 at around 50, 55. That lasts 5 years, and the surgery number 3, and so we go, and we just can't carry on like that. So a lot of the time, what what surgeons are trying to do is actually delay that surgery as long as possible, and actually try and manage the symptoms. And like we said, that it doesn't matter in a sense that there is a prolapse. What matters is your quality of life. So most people have prolapses in the second half of, if they've had babies, and especially if they're delivered naturally, have prolapses, but it's not a problem. It's not affecting them. It's the prolapse symptoms that become the issue. That if we can help manage the symptoms, then we're good to go. And really, when we get to, and that's where pessaries can come in, where we can delay. But ideally, we want to really go into the surgical option as the last resort, and try and really extend those surgeries out, that we're not going in our younger years, where we don't have the years to play it out. So that's one consideration with surgery. The other thing with surgery is that we need to realize that whatever so that is the anatomical correction of the the prolapse, the anatomy. We're correcting and trying to put the anatomy back into a normal position. Um, whatever caused that prolapse, um, and sometimes it's one of these things where the actual delivery caused it, and one can't change that. But there may be other things like the constipation, like the coughs, the heavy lifting, the exercise routines that are changeable. If we don't change that, even if you have a surgery, those exact things that caused it in the first place or added to it have not been altered. So you're very at risk of potentially having a recurrence of prolapse if that's not managed. So generally, the way that we used to work in our pelvic floor unit is that we would do even if we realized that, even if they thought that surgery was an inevitable option, or we couldn't avoid that, we'd always start with a conservative workup. So what would happen is we'd manage all those things, strengthen that area, and very often patients used to say, you know what, I actually am fine, I'm not 100%, but I'm not willing to risk the complications or risk surgery for the level of symptoms that I have now. It bothers me once or twice a week, or only with certain things, and I'm not willing to put myself through a surgery and take those chances. So even though it may look like it's a surgical thing in the beginning, often when we manage the conservative aspects, then it might not be. So we don't operate based on whether there is or isn't a prolapse. We operate based on whether or not these symptoms can be so we operate at the point when our symptoms are such that it's affecting our quality of life to that degree that we can justify this a surgical intervention. But surgery is not the kind of easy way out in these. It's actually not the easy way out. It's the last resort, and that's something where many of you who have kind of are in the audience and in our practices have had more than one surgery and understand this. But either way, whether we are looking at surgery or whether we're not looking at surgery, we've got to rehab the area. So just like you would have rehab after a hip replacement or a knee replacement, why would you not have management or rehab for prolapse surgery or pelvic surgery? So ideally here, so surgery weakens things by the nature of surgery. So generally, the way in which we get the best results is to do some pre-operative workup, have the surgery, and then we have a post-op workup. So then we check the muscles again, make sure that we're not kind of doing things to disrupt the surgery, and to keep everything in place. And that can have then a far better surgical outcome. So yeah, those are basically the management options with regards to prolapse. So I'm going to leave it at the short and sweet, and we're going to go into answering. So please ask your questions, and let's get into discussion around kind of the more nitty-gritties. I don't know if you'd like to add to this before we carry on, Hester.
No, I think you've discussed that in a good amount of detail. We've had a question here about, or somebody just saying, so if you've had a prolapse after a baby's birth, how do you correct that? And I actually think that you've touched on all the basic things that one needs to address, controlling the pressure, knowing what to do, how to activate your pelvic floor, making sure that your support is sufficient, really trying all the different conservative options, just like you mentioned. Sometimes even a pessary might be necessary, but it doesn't change just because you develop this prolapse from being pregnant. If it is really severe, obviously your doctor needs to assess it and you need to monitor it. But I think one of the common things that doctors will often tell the patients is give yourself a little bit of time. Your body has gone through a lot of changes after you've had a baby, and there's a lot of hormonal things going on. You might still be breastfeeding, that's also affecting your hormones. So give yourself time. Allow a year or sometimes even 18 months. And in that time, do what you can to manage things. So watch your bowels, do the exercises, make sure that you are taught properly how to do the pelvic floor exercises, because I do think for a lot of women, they think they're doing the exercises correctly. And then when we assess them in the rooms, we actually find that they are not. And people don't necessarily understand that until they've had a physical examination where we physically check the muscles. But all those basic principles apply, even if whether your prolapse is in the menopause years or whether it is directly after you've had a baby.
And that's exactly it, is that, if we're going back to the question around after pregnancy, like Hester was saying, the hormones, like when we've had a baby, it takes time for our hormones to go back to normal. So one of the things that the pregnancy hormones do is create laxity. So we are more likely to develop or be prone to prolapse in a lax phase of our lives. Okay. So and breastfeeding maintains the almost pregnancy hormones. It's like the after pregnancy, it's still the
Mm.
hormones are still there in the way that you're still quite lax while you are breastfeeding, and it takes time. So only probably about 6 months after you've stopped breastfeeding are your hormones starting to stabilize. So if you're thinking that you're breastfeeding for a year, then, and this is, and also with regards to exercise postpartum.
Yes.
So very frequently we kind of, and I say this having 2 young children, and I gained 20 kilos in each pregnancy, but it's kind of like, okay, the baby's here, I want to get my body back into shape. And that's when we start to do things that are not appropriate for our postpartum body and for where our hormones are. So we may decide we want to start running, or we want to do jumping jacks, or whatever, start weight training, because we feel flabby, or whatever the case may be, and it may not be appropriate for the
Absolutely.
time. And this is where our, actually having a personalized consultation related to your stuff can become meaningful, because one can look specifically at what is happening in your situation and in your circumstances. But generally we do rehab and we do all those things, and also get that. So postpartum, it can also be a situation of the tummy muscles separating. So there can be what we call a diastasis, and Hester's the diastasis guru. Maybe you can elaborate on how a diastasis and the pelvic floor interrelate.
Yeah, so what we see if we are starting to look at the core is that your core muscles are diaphragm, abdominals, lower back, pelvic floor muscles, and those four groups of muscles actually function together in normal life. So when we lift things, when we exercise, when we breathe, when we sit on the toilet, our core muscles are all working together. So when you have a diastasis, which basically means that there's been people often call it that they develop a gap between the tummy muscles. What it really means is that just there's been a stretching of your fascial tissue behind the muscle layer. And it means that you can palpate a little gap, but it obviously affects the way we control pressure in that region. And we've talked about pressure quite a lot this afternoon. But we come back to that. When we are moving and doing things, there is pressure in that region. And if our pressure control is not optimal, it is going to aggravate the problem. So when you've got a gap in the tummy muscles and you've got a pelvic floor that's struggling a bit because you've been pregnant, the combination of that can cause a little bit of havoc. And you need to understand how to start rehabilitating these muscles. And I come back to what you said earlier. An individual consult is probably really um, worthwhile because we can assess, we can see what's happening in your body. There's not a recipe. Somebody else asked about, so what exercises should I do? And there isn't a recipe for the same thing doesn't fit everybody. It depends on what's happening with you. Do you have lower back pain? Are you menopausal? Have you just had a baby? Have you had hip surgery? Because all of those things then might change what we do for your exercise program. Yes, I think the basics remain that you need to know how to breathe, you need to know how to activate your pelvic floor correctly, which is really important. You need to be able to coordinate the abdominal as well as the pelvic floor muscle function. And then you need to be able to integrate that into an exercise program, whether you do Pilates or yoga or weight training or whatever it is. You need to make sure that you are able to correctly activate, correctly support, and that will determine the level that you can exercise at. You do not want to be jumping on a trampoline if you can't even activate your pelvic floor lying on your back, because then you're certainly going to aggravate any symptoms of prolapse. But maybe if you're strong and you can train specifically, you might be able to go back to running or even do some weight training in a controlled manner. But it's quite specific. So just depending on what your symptoms are. And I also think something that's important is to think about, somebody asked about the exercises. So when you do abdominal work or abdominal exercise, to make sure about the load. And we can check that to see, okay, let's get you to do a movement. And if you're not controlling that load, you should not be doing that exercise. So it's not always about the type of exercise or what is wrong or what is right. Movement is good, but whether you are controlling the pressure in that movement, is that optimal? And I think that goes for any exercise program.
And I think if I can add to that, we're always looking at the prolapse as a weakness. So we kind of go, there's a weakness, and there is a weakness in that area, in the sense that the organ has moved out of anatomical position. So there will be a fascial change, there will be. But if we have a look at so that is a anatomical defect and a symptom-based complaint. Okay, I'm bulging, I feel heavy or whatever. And then we go, okay, I'm weak, I must do loads and loads and loads and loads of pelvic floor exercises, okay? And very often not very often, but what can happen, and in the more complex cases where maybe kind of a person says, but I have been exercising and this and that, and we've had failed surgery. Sometimes what's happening is that muscle is not relaxing properly. So there is a tension in that muscle. So yes, and long-term tension can cause weakness, okay? So suddenly you don't only have a weak pelvic floor, but you've got a tight, weak pelvic floor. So we always think a tight pelvic floor, like tight is strong, okay? Tight is not strong. Tight is tight. Strength is a product of what you can hold or contract against. It's a contractile property. Like tightness is tone. So I can be tight here, but like if you want to put 100 kilos on here and I got to lift it, I might not be able to. So I can be tight, but I can also be very weak. And usually tight and weak go together. And that can be complicated, because now suddenly, and this is where, again, and it's not about just kind of running in and, kind of always having to have personalized sessions. But what I'm saying to you is that if you're doing your pelvic floor exercises and you think you are contracting or whatever, and your symptoms are getting worse or not changing, it may be valuable to go to the next step. And it might be that the muscles are not relaxing. So as you tartan and tartan and tartan, you're making everything tighter. Now, when you want to go to the toilet, or you can't get anything out, and what happens is you push into all of the adjacent structures. So there is a time to contract and there is a time to relax. So if I want to be functional in my arm and I want to kind of have my glass of water, I need to be able to, my arm needs to have the movement. It needs to straighten, it needs to bend, and it needs to be able to do that at the right time. But if I've got a contraction on my bicep and I can't straighten my arm or I can't bend it to get the glass to my mouth, it's not going to be a functional activity. And sometimes what happens is the functional capacity, how it's functioning and in interrelating with what we're doing, can be the tricky part. So and again, I don't want to overload you with complexity, but these are just the little extra things that can come in. And very often the tight patterns and the emotional patterns can go together. So now this is kind of where, my other hats come in. So very frequently when we have very complex cases and when I say complex, not because they're complex, it's just sometimes we are boxed in a prolapse is weak, and if you tighten it, then it's, you're managing it, or if we have surgery, then it's like, if there's stuff happening and there's pain patterns and various other things going on, very often there can be an underlying tension pattern that can, and when there's tension, the muscles won't function properly. So they're not going to be able to support when it's time to support. They're not going to maybe be as strong as they need to be. And that tension pattern can sometimes come through from childhood. Okay, so if there is a childhood trauma, if there are what we call ACEs, adverse childhood environment, stress at home, the teenager might kind of show patterns of eating disorders, or whatever the case may be. There might be stress patterns that come through, or our dancers or our ballet dancers and things like that, they might have higher tone, and it may predispose one to dysfunctions in the area, and prolapse can be one of the dysfunctions that may not always be related to weakness specifically. So when we're talking about exercises, yes, we want to strengthen the pelvic floor. We want to be able to squeeze the muscles. We want to be able to let the muscles go. We want to be able to squeeze and be able to hold the muscles. And we want to be able to do that while we're breathing. So it doesn't help that we're supporting our prolapse beautifully while Hester said, like lying on the bed, and then suddenly when it's time to go for a run, everything's going because we're breathing, or we're adding other components. So but I always remind people that the body is very clever. Okay, so like often we don't have to get that complicated. If we just kind of put the right little pieces in, it almost like clicks in, and the body goes, oh, I know how to do this, and it follows on. Okay, but yeah.
Absolutely. Bettina, we've had another question of somebody saying, if I've been doing physio for about 3 months, but I don't see much of a change, am I going to have to go to physio every week forever? And I think we've addressed a little bit of that. You said it just now, that if you are doing the exercises and you're not seeing change in your symptoms, we need to assess and see why not. So does it mean that you are not doing the exercises correctly? Does it mean that you are maybe tight? Does it mean that there's something else that needs to address that one has not looked at yet? Sometimes it might be that you need surgery, although I think a lot of doctors, if your prolapse is not too bad, not too severe, will tell you to give exercises time. It takes a long time. It could take 6 months to a year to see a lot of progress. But I think over time you would like to see little changes, even if there's not major changes. But somebody who's not seeing good progress need to be assessed. Because yes, something is happening in the area. If it's really just weakness, for instance, then we can add maybe some electrical stimulation or biofeedback to try and assist the muscles to work better. They might really do well with a pessary, but they need to be assessed.
Yeah, so again, it's hard to kind of answer it off the cuff in that, because there are moving parts, and those moving parts become important in that personal, like, why specifically is this not working for you? And it could be, if you're postpartum, it might also be related to kind of a hormonal thing. It might be
Yes.
related to a stress factor. It might be related to, so if you go to the gym and you want to strengthen up and you're really diligent about it, 3 months is not a long time. So
Yes.
when we're looking at strength training, um, 3 months isn't actually long, which sounds almost a bit demotivating, going, oh, like, and I've often sometimes gone, let's not get, I don't necessarily believe that having more intensive physio, like now you must come once a week or 5 times a week, is necessarily the solution to that. I think it's about having a look at what's going on. So are you remembering to do your exercises? Are you doing them regularly? Are you incorporating the strength and the learning? So initially there's a learning component to the exercises. Like the muscle needs to wake up and like realize, like, come on, come to the party, like why are you sleeping? So there's this like wake up phase, and sometimes muscles have really gone to sleep, okay, for a long time, and it's hard for them to wake up. That it's a bit of a hit and a miss. So like, you may actually be thinking that you're squeezing, and out of the 10 that you're doing, maybe only 3 are activating. So you're really only getting 3 out of 10 potentially. So that type of thing. So there's a learning phase attached to it, and there's a strength phase attached to it. But um, so just bearing that in mind, and the consistency of it, and incorporating it functionally, that you're actually bringing the exercises to to your day-to-day activities. The other thing is what other stuff's happening. Like, are you a granny that's looking after your young grandchildren, and you're having to lift them or carry them? Are you in a career that requires you to be quite physically active? Do you have a chronic cough? Have you just been sick? Are you, every time you kind of go through a flu season, we don't even want to talk about flus in this time, yeah, but the kind of traditional idea of having a cold or a cough or whatever, often they may feel like there's a bit of a relapse of symptoms because there's been that ongoing cough, and it takes time for it to settle again. We strengthen up and support the area. So there can be a lot of moving parts in that, but I don't necessarily think that having a lot more physio is always going to fix the problem, unless you're needing additional support, like with like electrical stims or biofeedback, because you're actually not able to engage the muscles yourself. So that's different. Like, if you can't engage your muscles, it's almost like you can't help yourself. But if you can engage the muscles, then we may need to tweak kind of what's happening there, and look at that a bit more carefully. And there might be something that you're doing in your day-to-days that maybe is aggravating it. That as much as we're trying to improve it, you constantly kind of, it's maybe 2 steps forward, 1 step back, 1 step forward, 2 steps back.
Yeah.
And again, it's, prolapse is about how do you feel, more than what it, it's a symptom based assessment. Yeah, I don't know if whoever asked that question, if you want to give more information, then I'm happy to elaborate. If you want to just, we obviously won't disclose anything, but so it's you're private in that regard. But just giving us more information will maybe help us answer that more specifically.
Hmm. Yeah, that person can maybe ask if there is anything more that they want. We haven't had any other specific questions. I think somebody else asked that whether a cystocele and bladder leaking goes hand in hand, um, and it can, depending on what's happening with the anatomy, with the muscles, with the function. It need not necessarily be related, but it could be related. I just typed an answer for them there
So
regarding that.
this is a tricky one because we have. Was it specifically leaking that was?
Yes, yes.
So you can leak with a prolapse and you can leak without a prolapse. Because you're leaking with a prolapse, it doesn't mean that the prolapse is causing your leaking or the prolapse isn't causing your leaking. It's hard sometimes to say, okay. And I think this is where for me personally, I almost put them in two different categories. It's like, okay, you have incontinence and you have a prolapse. And this is how we need to manage the incontinence. And this is how we need to manage your prolapse. There is a overlap in those circles, so
Overlap.
that yeah, there is an overlap both in the management or in all of it. But I think where this becomes a tricky discussion is the if we're looking at a surgical intervention, because if we're looking at surgery, I've had numerous experiences, and maybe you can relate to that, where people have had exactly this and have had surgery. So they might have minimal, like once a week, or occasionally they'll feel like, oh, it's a bit heavy when I've gone for a long walk or I've been lifting or exercising. But the main thing that's bothering them is actually the incontinence, which is a daily thing. The heaviness, the bulging is maybe a once a week thing. And when surgery is offered in a situation like that, it's very important to realize that you're having the surgery for the discomfort, the bulging, the heaviness, because it's prolapse surgery. The incontinence may or may not change, because it may or may not be, it can actually get worse sometimes. So let me just go back to and then I'll elaborate on that. But it doesn't mean that if you correct the prolapse that the bladder symptoms will change, okay, and improve, because they may actually be slightly separate. And sometimes it actually happens that it'll be the other way around. So but if we go to that picture of, I leak every day or 5 or 6 times a week, but I have heaviness once a week, I would not encourage somebody like that with that presentation to go for prolapse surgery, because the once a week may not justify what we actually the surgery in and of itself, and you may come out of that surgery with your bladder being exactly the same, okay, because it's a prolapse surgery, not an incontinence surgery. So that's something, and that's where I've had a lot of disappointment going, but I thought that I'm leaking like this because of my prolapse, and why am I still leaking now? For other people with the bladder specifically, because it like almost leans over, what happens is the tube that you wee out of, like, it's kinked a bit, okay, and that can sometimes help with your incontinence. So when we straighten it up, if you're not strong enough to kind of close that area up, sometimes you may leak after a prolapse surgery. So the heaviness and the bulging subsided, but suddenly it's like, but I'm
Leaking is
leaking
worse.
now. So and this is the reason why sometimes when they have surgery, when they're offering surgery for the anterior or the front compartment, the bladder, what actually is happening is they often do an incontinence surgery with it. So they'll put a sling that actually supports the incontinence component, but they are a little bit different, okay?
Yes,
They can be together, but they needn't be together. And it's hard to
exactly.
discern that. And sometimes after the surgery, when it's not better, that's when we know that it's separate. But that's not a great way to find it out. But they can go together. And also what's causing the prolapse can also cause the incontinence. So if you've got a weakness in that area, and if you've got laxity in that area, it may translate into other symptoms. Or if there's tightness, that can also cause irritability of the bladder. And again, we haven't done a webinar format on urinary incontinence, but I did it in another format. But what I'll do is I will upload these onto YouTube so they are available for everyone. But I didn't feel that a meeting format was private enough for the way for me to want to put that up onto a platform like YouTube. But when we talk about the incontinence side of things, there's also different types of incontinence. So we have different ways in which we leak. We don't just leak, and the pathophysiology changes. How the leak is happening changes, and how we manage that leak will be slightly different. So it sounds quite complicated, but I think if we can just almost keep the boxes separate before we put them together. When we look at the big picture, we have to put it all together, but sometimes it's easier to separate them out slightly when we're looking at management and diagnosis and stuff. Right, is there anything else? If anyone wants to comment on anything else, or if there's any other
So
questions,
hang on,
now's the
let's
time.
just have a look here. There's another one, Bettina.
Mhm.
This is asking what's the best approach when the prolapse results in constipation and almost a blockage has been created to passing even gas on some days. Working on muscle control is challenging when the blocked feeling is due to the position of the prolapse. Yeah, so when the prolapse actually results in constipation, and I think that is more
So,
often where that the way that the bulge is almost covering that anal opening area, meaning that instead of the stool able to move through very well, it does instead of no. And how to deal with that and manage that can sometimes be a little bit tricky because there's different factors affecting it. I think as part of our management, we really focus quite a lot on how to sit on the toilet properly, trying to make sure that you are relaxing your muscles well enough, trying to make sure that you are not having too hard stools that you want to push out, that it's soft, that it can come out easily, that you use Movicol, for instance, if necessary, to soften your stools. But then also realizing that in some situations, if the prolapse there is bad enough, nothing that you do will help you to empty fully. It might be improved, but it might still not be complete. And that might be such a quality of life issue that you eventually decide to go for surgery. Um, the other thing, there is that little tool, the FemEase, that looks like a spoon almost, that you're able to insert into the vagina, and you can gently push to straighten out your anorectal angle to try and empty better. It's something that is available. In South Africa, we need to order it from overseas. It's not available directly in South Africa, but that could be an option. But that can be tricky.
and I think again, if we're talking about what's happening in the front with the bladder and the prolapse, kind of the incontinence and the prolapse, at the back we have that same chicken and egg kind of interplay with the bowels, and emptying our bowels and the prolapse. And it's hard to say which is causing which, okay, at any point in time, because and this is why I think it's really valuable to do the conservative stuff first, because very often when we have stuff going on there, we change the functional components, how we try
Yes,
and empty,
yes,
we do, and
absolutely.
what can happen is that if there is tightness, so and sometimes we're not able to answer these questions, but just from a discussion purpose, it's a food for thought. Okay, so it's a chicken and egg. What came first? Okay, and very often there can be a dysfunctional defecatory pattern, as we call it, like where we're not able to relax the muscles correctly, where we can't get the right pressure down, and that actually causes the prolapse to block even more. Well, firstly, it can cause the prolapse. If the prolapse is there, it can even cause it to block it even more. So it becomes like a tricky component of managing that. But the more you push, because it's not coming out, the more you're pushing the prolapse to block it. So we've almost got to step back and, like Hester was saying, just try and start managing how the muscles are working and assessing that correctly. Are the muscles able to relax? Are you able to generate a good kind of push into that area? Because it's not really a push, okay? It's actually a let go into emptying the bowels, which can feel very confusing if you've never done that, and especially if your normal pattern is pushing. It may mean that we've got to just assess what's happening with the muscles, because if we change that, and things can work better, and as Hester said, if we change your stool consistency, that you're not getting, that you're not trying to kind of maneuver hard stools out, and various things, and we get that balance right, what you might find, and this is frequently what we find, is that the whole little kind of situation settles a bit. It doesn't necessarily go completely away, but enough that you can empty your bowels without causing too much of the prolapse to block the area, and functionally in your quality of life, it can be managed. And there is no need to necessarily have surgery. But if your muscles are working properly, or as best as we can get them, we've looked at the various kind of aspects around the stool consistency, and really it's not shifting, then you're likely to do quite well with surgery. But again, if you go and have surgery to lift things up, and in your first 1 or 2 bowel movements you go and give a nice push, you've disrupted that surgery again. So I would start with actually trying to, like, it's a bit of a balancing act, and if you can get the balance right, and yeah, then you may find that your symptoms are okay enough for you to not have to have surgery. And if you land up having surgery, you know what to do and what not to do, the muscles, and that's where we do the post-op rehab, because kind of when we've moved things around, the muscles may be a bit confused, going, okay, I don't know how to do this anymore, and we may need to teach that, and then you're good to go, and you're less likely to have a recurrence because everything's functioning well. But again, this is where it gets, I wanted to give a very clean prolapse picture, and then we can add the complexities in. And this is one of the complexities of the posterior, the back compartment. And as Hester was saying, that if, as you're emptying, the stool is pushing into that pocket of the rectocele, a device or even just a thumb. So really just, if I can get the right angle here, like if it's pushing and you're getting a bulge there, you can't just support kind of that back wall of the vaginal passage. So if this is the front and that's the back, you can just actually just put your finger there. It can even be external, so we call it perineal support. It doesn't have to be internal, but for some people, and we call it digitation, and people get quite like, they feel a lot of shame around this, but this is practicality, like if it's really coming down and you're feeling that bulge, you can just kind of give a little support. Even to the thumb is the easiest by the nature of the anatomy. So when you're kind of sitting on the toilet, it's easiest to push towards the back with the thumb. And you can actually just put it a little bit, like maybe a centimeter or 2 into the posterior vaginal canal, like the back part of the vagina, and just support it. Like you don't need to go and push it and do funny things, but just support it so that when you're pushing, it's not bulging into that, you're just giving a little bit of support for the stool to come out. But it's not a support so that you can go and like push everything out, because that's the mistake that people make. They're so readily going to support and give a good push, but remember, everything inside is going woo as you do that.
Yeah.
So you might only have a rectocele now, but in 6 months or a year, you're going to have an intracele and a uterine prolapse and a cystocele and a disc bulge and a whole lot of other problems. So if you are supporting, be it outside or be it into the vaginal wall, just bear in mind that it's not a support so that you can give a hard push, okay? It's a support that you can continue just allowing the bowels to gently open and empty on its own. So when we're looking at bowel emptying, it's not you that is doing the emptying. It's the rectal wall that's doing the emptying. So if you look at physiologically how we empty the bowels, the stool comes into the rectal wall stretches, and that stretching gives a signal to the brain, I need to poo. And then we have a hopefully, or in a normal anatomy and physiology, we have time to get to the toilet. And then what happens is that when we relax the pelvic floor, that gives the cue to the rectum that, okay, I'm ready for you to empty, not me to empty, for the rectum to empty. The rectal wall then contracts rhythmically to pushes the stool down, and it's actually the rectal wall that pushes the stool down, not you. What you are doing is you are letting go to activate the correct pathways to tell the body to get on with what it knows how to do. And this is the problem with the prolapse getting in the way, is that we get in the way, and we need to get
Mm.
out the way
Yes.
and try and get the body to just relearn how to do this. And sometimes that's easier than other times, but that's ideally what we're aiming for. Um, but that
Absolutely.
additional support can be valuable, but again, it's about just giving that little bit of support and allowing the body to still gently empty itself. So yeah.
Mm. So true. And I think something I like to tell my patients is that we should breathe the poo out, just like we should breathe our babies out and not push it out, because the body knows how to do it now. So I absolutely agree with you there, Bettina. We've had two comments. Just one saying that somebody using a pessary said it was life changing. It has really helped her a lot. And we see that in the right circumstances, that the pessary can really be valuable. It doesn't work for everybody, but for some people, it's wonderful. And another comment from somebody just saying that she wants to encourage people with a rectocele to ensure that the consistency of the stool is right, because, yeah, and the way you sit on the toilet and using her thumb has really helped her a lot. So all these little things
And
play a
this is
role.
not coming from us, and this is a nice
Exactly.
thing about this. And I really encourage you to share. And this is where I say to people, if you can, like, I wish as women, we fail ourselves deeply in not sharing with each other, because the things that I hear about every other cream or what, like, yet no one wants to say, like, I've got a prolapse and this is what I do, because there's shame attached to, I have to support with my finger and I've got to sit like this and I've got to breathe and whatever. But really, it's by sharing these types of things, we actually normalize the experience, because
Yes.
this is quite normal, or let's say it's common, okay, and also it reframes our as women, it reframes our expectations around things. And sadly, we only share the gory things of the terrible, like, failed surgeries and whatever, but we don't kind of really support each other in that. So I do encourage a lot more communication. So thank you for sharing. um, and with pessaries, that I do have some people that say no, they're not. They that doesn't work for them. But like I say, it's worth a try. You've got nothing to lose. You take it out and, there you go. Yes, there is a cost involved and there is a time involvement, but once there's a surgery, you can't go and reverse stuff anymore. So, I am personally, my personal capacity, a conservative person. So to me, it makes sense to really examine your options before you go into something that is not reversible. Um, so yeah. Right. Is there anything else or any comments that maybe you have, Hester? And
I think one really just wants to encourage people that having a prolapse should not freak you out. You shouldn't be desperate about it. I do think there is a lot that one can try and do to improve it in a conservative fashion without surgery, and give all of that a try. Make sure that you've done your part. Um, there's no quick fix. Surgery also is not a quick fix, because if you've talked about it extensively, changing or managing how you function and managing what you do every day is such an important component of managing a prolapse. And if we don't do that, you're not going to be successful in managing this, whether you have surgery or not. So really do what you can, um, yeah, with your exercises and your management and changing the way you do things, because that in itself might really be enough.
also, I think setting realistic expectations for ourselves is also
Yes,
important.
so true.
So, often people will say to me, but, I like 3 times a week, I'm uncomfortable. And I'll say, but have you tried to lie down in the afternoon just for 15 or 20 minutes,
Yes.
or just push it up again and maybe put some pillows under your bum and just rest your body? And sometimes something as small as that, of just allowing us and giving ourselves permission to just rest, okay? Um, and then it's okay again, and we can carry on. And the
Mm.
question is then, do you still feel that surgery is the way forward or not? So it's being we need to be gentle with ourselves. We need to be realistic with ourselves. And I think if we look at our grandmothers and great grandmothers, I think a lot of them did have prolapses. They probably didn't talk about it much. Um, but I think it was more normalized, kind of like, it's like, okay, I've had children, and I think they've managed it better. Whereas I think also we sometimes have unrealistic expectations of what we should or shouldn't be doing at certain ages, and our activity levels, and what is realistic around, after you've had children or after menopause, or like is this normal, to actually be doing certain forms of exercise at certain ages, and I don't think a lot of it is normal. um, it's not
Exactly.
it's not matched with the body and where the body's at in that time. It's not normal to go back and have a gym trainer like at 6 weeks postpartum and start to do intensive. It's not normal. Or to, I don't know, I have my reservations with these CrossFit type of exercise programs. It's very intensive at those times.
Very,
So I think we just
very
need to reframe. We go through trends. We go through like societal trends, and then we think we're not normal because we can't fit into the trend. But is the trend normal, is what we do need to ask ourselves, and is that realistic? And are we setting ourselves up for unrealistic expectations? So
true. Yeah,
okay.
good.
Okay, I'm just checking if there's anything else. There's
Don't
just a
see anything.
comment here about rest, and that just see knowledge is power. Absolutely. Um, so this person's just commenting, saying, the more that I know, the more I'm encouraged, and I realize I have to change my lifestyle and add the exercises specifically designed to my own personal body and needs. Absolutely. and this is what Hester was saying, there's no recipe here. And we don't want to be prescriptive, but in the same time, our vagueness is not a lack of, it's just that prescription is not always the best way forward. And that rest is very important and an important part of the day. Our grandmothers always took a half an hour nap. Yeah. With that knowing that they were actually being kind to their bodies. I think we're very unkind in our modern world to ourselves and our expectations and what we do in a day and what we think normal is and how we should be keeping up with the Joneses and whatever else is going on. So yeah. All right. I think we can. We have run over time, but we are here for you at this time. And as I say, we'll upload it, so it'll be available to all of you if you ever want to go back and relook at it or share it or whatever. But I hope it has been meaningful, and we are available if you want to. Chat more specifically or whatever, we are available to help you with that. All right, Hester, thank you so much. And we're going to love you and leave you. I hope you enjoy the rest of
Thank
your afternoon. And yeah,
you.
we'll
Yes.
see you for our
Thank
next
you, everybody
webinar.
attending. Absolutely. Have a
Okay.
lovely afternoon.
All right, good. It's already evening, so enjoy your evening and all the best. Bye.